My screen visible?
Yes, sir.
Okay.
Yes, sir.
So, simulation in anesthesia training. Over the years, the use of simulation has gone from low fidelity to high fidelity models that mimic human responses in a startlingly realistic manner. So it is nowadays the modern simulation mannequins or the gadgets that we use, they all almost look like a real human and extremely lifelike mannequins that breathe, that have EKG, that has pulses, heart sounds, and an airway that can be programmed for different degrees. Okay? So simulation anesthesia is no longer a research fascination, but an integral part of your training. It is rational to assume the relationship between simulation training and patient safety. So anesthesia has often been compared to aviation industry. So we used to say just like takeoff, flying and landing, we used to compare it to the induction, maintenance and recovery. Okay, these three phases are compared to the takeoff of the plane, cruising of the plane and landing of the plane. Some pilots you would have experienced very smoothly come and land down, whereas others give you a jolt when they land. So similarly, your recovery also can be very smooth under some experienced hands. Sometimes it may be very drastic and very alarming when the patient is coming out. So that is why it has been compared to the aviation industries. The passengers entrust their lives to pilot while patients undergo anesthesia entrust their lives to the anesthesiologist. So that is a major comparison. And both are high risk systems with minimal tolerance for any error. So you should not make any error, otherwise there is a great risk to the life of the patient. One of the most important reasons cited for the improvement in the safety of aviation industry has been the routine use of aviation simulators in the training of pilots. So simulation can similarly be used in anesthesiology curriculum to train residents. So copying from them only, we have introduced that. So simulation in medical curriculum means recreating or imitating part of some clinical scenario for purpose of training, or later on it has been used for evaluation also to see how far the candidate has trained himself over a period of time. So simulation scenarios can be used for orientation to new procedures. These are all the purposes. Exposure to uncommon clinical scenarios and assessment of knowledge. These three things are very, very important. Orientation to new procedures, exposure to uncommon clinical scenarios, and assessment of knowledge. This, by giving the simulation training, it accelerates the skill acquisition. So if you want to train a newcomer coming into anesthesia for intubation, you can't be giving him all the chances every day. So other students also need to learn. So he may get one or two chances per day for a live patient. But in simulation, he can do any number of attempts and accelerate or improve his skill much faster. And it helps to retain the skill that he has learned and reduces the extinction of skills. That is, you don't forget it. So three things are achieved. It makes you learn faster, it makes you retain your skill, and it prevents you from forgetting that skill. So in addition to helping with the technical skill, simulation training also help reinforce non-technical skills such as the task management, leadership, team working, situation awareness, and decision making. These are called the non-technical skills of anesthesia. So anesthesia non-technical skill are ANDS. That is also improved by giving this technical simulation training. This also has to be included in this. These non-technical skills are vital to patient safety in emergency and crisis situation. And a usual simulation experience consists of three components: the initial briefing, the actual simulation experience, and the debriefing. These are the three components of a simulation experience. Initially, you tell the student how to hold the laryngoscope, how to introduce it, how to visualize the glottis. Then you allow him to do and watch how he does it. And then at the end of it, you point out where he went wrong or how he did it correctly and tell it to the other students also. So briefing and debriefing are the first and last part, and actual performance comes in the middle. And debriefing is the chief component of simulation that allows trainees to understand their decision-making process, which is the first step in changing their clinical practice for better outcomes. And rationale of using simulation in anesthesia, why we are using it. It is interactive and innovative educational tool that can build confidence, improve the knowledge through practice, and enhance team performance. So again, if you see, there are three important things or components. It builds confidence on the trainee, improves their knowledge by repeated practice, and team performance. When they work in a team, they know how to cooperate and work in team performance. Then anesthesiology is a hands-on specialty. So as in other hands-on specialty like surgery and emergency medicine, the only way to master a skill is to practice it again and again. So that is the biggest advantage. You can do any number of attempts in getting a central line or performing a block or putting a tube, airway management. Everything can be repeatedly done without any risk to the patient. So it provides a safe learning environment and where anesthesiology residents, students can be taught, practice, and be evaluated. We can see how fast they can learn, how quickly they are doing the skill that they have learned, and evaluate it without putting a real patient at risk. That is the biggest advantage. And anesthesiology, in fact, is the pioneer for introduction of simulation into medical education. Anesthesiology was instrumental in the development of high-fidelity human simulation used for medical education and in other medical specialties as well. Widespread use of simulation in anesthesiology is to provide crisis management training also. So when you take this simulation training to other specialties, you train them in crisis management, because as an anesthesiologist, every day you are facing crisis situations. Like when you take even a ASA 1 grade patient, until you intubate successfully and connect him, when you give GA or give spinal successfully, you are always, you may have to face some degree of problem. And however much you are confident, you always do that with some consciousness so that no harm is done. Primum non nocere is very, very important. Even starting an IV line, and if you are able to get it in the first shot correctly, it is good. If you are not able to do and you are punctured 2-3 times, it is a harm you are doing to the patient. It may be a difficult venipuncture, but we must try to do the best to the patient. So in the crisis management training is very important when this simulation is being taken to from anesthesia to other specialties. And simulation allows residents to experience clinical scenarios that are infrequent in daily practice, but critical to anesthesia practice, such as use of bronchial blockers or WM endotracheal tube placement, or for that matter, a cricothyroidectomy. All these rarely done procedures also can be easily learned by this simulation. Although predominating use of simulation anesthesiology is to educate in crisis management, it is also used to teach routine anesthetic management also. So earlier it was mainly meant for crisis management training, but nowadays in USA I was told that it is being included as part of the training curriculum, and marks are given by the students performing with the simulator, and pass mark also is important in simulation lab also. In addition to anesthesiology residents, the simulation setup can be used to give hands-on training to other people also. There are inherent limitations to teaching in the operating room, in addition to natural distractions that are hampering. So you cannot do all the teaching of practical skills in the theater all the time, because you have to take care of the live patient, you have to monitor them, so that may interfere with the patient care. So you have to, that is the reason why simulation is give you a lot of relaxed free time. So balance in the OT, you have to balance between patient care and education needs to be considered, and you have to do a correct job of doing both. simulation provides a platform for training in a risk-free environment. Coming to the history and evolution of simulation anesthesiology, the first ever simulation model worth mentioning is Ledler's Rescue Annie. This was the mannequin that was there. It was a simple model designed to teach cardiopulmonary resuscitation. So this was the first ever simulation that was used. The first true moderate to high fidelity anesthesiology was made in 1960s in University of Southern California. Called SIM-1. So SIM-1 was a lifelike prototype of the anatomically shaped chest that moved with breathing, eyes that blinked, pupils dilated, constricted, and jaw opened and closed. So the Rescue Annie was a mannequin which just like a toy by a child, whereas the high fidelity model SIM-1 had all probably the reactions that a normal person would have, and this is the SIM-1 which when you pump it, the chest moved, the pupils reacted, the jaw opened and closed. So all these things were included later because of other improvements in the hardware and software. Now, introduction to software-based simulation. As the mathematical models of physiology and pharmacology became clearer, they could improve on the software. So computer software attempted to simulate the normal human responses. This is the basis. The mathematical models of physiology and pharmacology became very, very clear. So we can jot down I don't know how many of you know about software. You have to write the program. So that programming is mainly by mathematical means. So that was possible because of this particular improvement. And in 1952, Philip J.H. introduced the Gasman software teaching the pharmacokinetics of anesthesiology administration. Then the high fidelity simulators in 87, David Gaba. He is considered the father of simulator marketing of Stanford University, developed a very realistic physical simulation system which he labeled as comprehensive anesthesia simulation environment. So CASE is the abbreviation or acronym for that. CASE was primarily built with anesthesia crisis resource management. So initially it was only for crisis resource management. Then around the same time, J.S. Gravenstein in the Florida University made another model which is called Gainesville Anesthesia Simulator or GAS. So CASE and GAS were the two high fidelity mannequins that were introduced. It was a very sophisticated simulator that could imitate breathing, generate a pulse EKG, and a lung that followed normal physiological calculations to consume and eliminate gases accurately. So it is almost like a human being. And there were hidden sensors on the functionally intact anesthesia machine that recorded users' action, which were used in providing a feedback. So the simulators in use around the world today are updated versions of the above simulator. So whatever newer versions you have are all based on these two, David Gaba's CASE and Gravenstein's GAS. Now, current state of simulation in anesthesiology, the present day commercially available simulators based on the following three categories. They are based on the mode of interaction, whether it is a screen-based, hardware-based, or virtual reality-based, I think which you, Pavitra, mentioned, and physiological models that are used, and they're used to teach predominantly psychomotor skills or cognitive skills. So these are the three categories of simulators that are available. And where are simulations are used? Simulation in airway management that all of you would have seen. Every conference has got a airway management workshop, and many of you would have attended that. So airway management is primarily a psychomotor skill. Hence, simulation training seems very suitable way to teach such skills. Fiber optic orotracheal intubation is a complex psychomotor skill indispensable to practice of anesthesiology. However, residents often have limited experience. That is why you go to the conference, immediately you are given a FOB and asked to intubate. So this is simulation can cover this gap in training, that you cannot have a fiber optic training in a live patient all the time. So you train in mannequin and then you go, you will be more confident in doing it because it's primarily a complex psychomotor skill. Then simulation in regional anesthesia has proved helpful to use ultrasound guided regional anesthesia blocks and also for pediatric ultrasound regional anesthesia. Both adult and pediatric, you can get trained with that. And simulation in obstetric anesthesia, there are four broad uses of simulation in obstetric anesthesia: improvement of technical skill, non-technical or teamwork skills, individual clinical competence, and the safety of clinical environment. So these are the four things that you have to follow in obstetric anesthesia. Improvement of your own technical skill. Sometimes giving a spinal in a pregnant patient may be very challenging. And non-technical or teamwork skills. When there is a postpartum hemorrhage, you need to work in synchrony with all the other people. And individual clinical competence. So performing a skill as an individual and the safety of clinical environment. All these things are taught in simulation in obstetric anesthesia. And technical skills such as epidural or estimating volume of blood loss can be effectively taught via the use of simulation in obstetric anesthesia again. Similarly, videotaped simulation sessions can be used to teach team communication skills, what to do when there is a major obstetric hemorrhage. All that can be videotaped and you can use them for training. And the volume of cesarean deliveries under general anesthesia has significantly come down because regional is the ideal method for cesarean delivery. So this gap, so many students do not get a chance to do a GA in a live patient for cesarean delivery. So educators have advocated the use of simulation training to fill this gap in the trainings. And in cardiothoracic anesthesia, there are recent technological advances, and in cardiothoracic and vascular becoming increasingly complex. So trainees have to learn the intricate skills in a short period of time. After all, your training period is only 3 years. So within that time, and your posting in cardiothoracic may be hardly for 1 or 2 months. So within that time, you have to learn that. So which again can be easily learned if you have a simulation lab. And simulation allows them repeatedly practice such skills and management of complex cases in low stress environment without putting actual patients at risk. Again and again, this is the prime advantage. You are not putting any patient at risk. Simulation is very helpful to teach the concept of transesophageal echocardiography, which is being taught nowadays as part of cardiothoracic anesthesia. And teaching non-technical skills and using simulation, the participants were given didactic instruction and relevant topic before simulation experience in the actual OR. The simulation was videotaped and used in debriefing session. The idea is to put the resident in actual OR setting and the actions observed from another room as not to become part of the scenario. And simulation training known to not only self-reported confidence but also clinical performance also can be evaluated. So this is the advantage. So if you add, I think all these points, that will be